to the meeting. I think there's quite a few in the waiting room. So perhaps first of all, before we start, just Happy New Year to everybody I haven't seen so far. I know we're some way into the new year now, and it'd be remiss of me if I didn't draw our attention to the efforts of everybody over Christmas and the new year and continuing into the new year with the incredible demand we've seen on both health and social care. It's not easing up on us, but I know everybody is really putting their arm to it and it's making a big difference. So a big thank you. Today's meeting was not, I wouldn't say it was hastily arranged, but it wasn't in the calendar originally. So we've lost a few people, but it is online for that reason. But we hadn't had a public board for some time, or for a couple of months. So hence why we've got the public board today. We should run until about 12:30. We've got quite a few members of the public joining us. I won't go through everybody's names because it'll take me a bit long, but you'll see they'll start joining us online. First of all, I would say, just a reminder to those people joining us, it's a meeting in public. It's not a public meeting. There is some questions. I've had 4 questions tabled, which I'll try and deal with at the end of the board meeting, if we possibly can, obviously time permitting. If we can't do that, then we will actually give a full written response to everybody for the questions they've asked. So we will make sure that we've covered those items. So if I can move to the apologies I've got. So I've got Jaya and John, who are 2 of our NEDs, John Martin from SWAST, Rosie Shepherd, our chief nurse, but Denise is representing Rosie at the meeting. Joe Walker, but I think Hayley is representing Joe. Mark Cook, but Richard, I know you're here from NHSE's regional team until 10:30. And I've got an apology from Aisha as well. So I'm looking to Rob or Lauren. Any other apologies I haven't covered?
Just that Health Watch aren't here today, Jeff.
Of course. Yeah, Health Watch as well. And people know that the contract is changing with Health Watch, but we've had a couple of apologies there. So anything else on apologies before I press on? Okay, can I just move to declarations of interest first of all? Is there any declarations of interest anybody has that we haven't recorded already or they want to bring to our attention? I can't see any hands going up, so I'll move us on. So the last public board we had was on the 3rd of October. The minutes have been circulated for that. People are happy to agree those minutes, or is there any issues anybody wants to raise regarding those minutes? Okay, nothing. And actions wise, I think there was just one update on the actions, and that was one around the digital strategy delivery. Deb, I think we were going to make sure that was fed back to the national team. I don't know whether that's been done.
Yeah, so I've got a conversation with Liz Clow, who's the National Director for the NHS app, in 2 weeks' time. So we'll be able to do it there. Rather than just sending an email that would get lost, I thought it'd be better to have a conversation and we can talk it through. Brilliant.
Thanks, Deb. So I'll move us on to the CEO's report. It's been circulated for you, but over to Shane.
Thank you very much, Chair. And colleagues, as always, I just bring to you the 3 big things. I think it's important. Quite clearly, there are many other things happening in health and social care, but it is the 3, what I commit to is to bring the 3 big things. This month, what I have brought to you, and I'm not going to go through in detail, you have the paper, are, I think, 3 huge issues that we are managing really quite positively, 2 of them. One is the reform of elective care for patients. One is the new model for community health services, and then obviously we have a challenge with regards to winter, etc. People will be aware that on the 6th of January, NHSE issued new guidance with regards to the reform of elective care for patients, and there's a link in my update to the guidance. What I've tried to do is just summarise for you what is in the guidance. This is a really important piece of guidance for us as a system, because it's setting out a clear expectation for us as an ICB and a clear expectation for partners as to how we are going to hit the target of 92% of patients being seen RTT, so referral to treatment, in 18 weeks. So you can see from the paper the kind of things that the key commitments in the policy are. It's about empowering patients, giving patient better experience, a big focus on health inequalities, which I was delighted to see when I read the paper. And then also about how we reform delivery. Quite clearly in there are other issues about how elective care will be funded, and also to go back to even just the point we had 60 seconds ago about the app, the importance of the NHS app and how that will really impact in terms of elective care. I've also tried to call out specifically the ICB's potential responsibilities in that guidance as well. And you can see, you know, we have a really important part with regards to health inequalities, patient awareness, etc. Not going to go through details, Chair, but it's a really important piece of policy because it does set the direction and the real challenge for us as a system to move to that place. We are in a good place with regards to RTT, referral to treatment, compared to many other places in the country, but we're certainly not at 92% in 18 weeks, which is the objective for this Parliament. So that's the first thing, the really important bit. We have an operational delivery group for elective care. That's a system-wide group that looks at how we improve elective care, and this becomes quite clearly a main agenda for that group and a main agenda for us as a board, and we'll be bringing it back regularly through the performance reporting in terms of how we are doing against that plan or that strategy. The second thing I want to raise to the board, and although this isn't policy or guidance yet, I think it's fair to say that based on the 3 shifts and a lot of the work we're doing in the 3 shifts with regards to the 10-year strategy, so the 3 shifts being hospital to community, treatment to prevention, analog to digital, there is no doubt that the ICB's responsibility will be to develop and deliver a new model of community health services. And really what I'm bringing to the board today, Chair, is my view of what that may look like. And in particular connected to our review of localities and the role that localities play. I think there will be a real strong requirement for us to work really tightly with local authorities to develop a new community model of health and social care, which has to be based around the value of primary care and community care and multidisciplinary teams in our neighbourhoods. Big question about what is a neighbourhood, okay? And today this is an update, but I think there'll be lots of debate about, is a neighbourhood a geography, is it a collection of similar types of population, all kinds of questions. In a neighbourhood, 30,000 people or 100,000 people. So we're not going into that today, but what I'm raising to you, Chair, is this will be the business of the ICB in 25-26 to make sure we can create a new model of community, locality-based, neighbourhood-based health and social care. Okay, and I've raised that. And the third thing I've raised, Chair, I think it's really important, and you reflected on it in your opening remarks, is that it has been exceptionally hard for health and social care over the winter period. You only have to look at the news. At one point last week, or maybe 1.2 weeks ago, there were 20 trusts who were in critical incident around the country. I mean, this has been a very, very, very strong winter. And I think what I wanted to raise to you, Chair, is that we did, on the 9th of January, find ourselves in a place where we had consistent pressure in Opal 4, which is our highest level. And we did then, as a system, come together to initiate what we call a gold meeting. I appreciate gold in many cases is about a regional and national issue, and Chair, as an ex-Chief Constable, gold to you is something slightly different, and I totally appreciate that. But from a health perspective, we raised it to a gold. And you can see, Chair, we came together. There is no doubt we would like to be able to do more, and we all know the resources that we have. We are and would like to have done more, but with the resources that we had, the actions that we took, and how that has been implemented. So, Chair, I'm happy to take thoughts, comments, or questions on the paper.
Okay, thanks, Shane. Awful lot in there, I suspect, and some of it we'll cover on the agenda today. And dig into a bit more detail. But can I ask whether there's any comments or questions from anybody on Shane's update? So I've got Ellen first.
Shane, thanks for the update. So 3 really key areas, so I appreciate that. In terms of the last point that the point that you made on model of community care, really appreciate that. And what should be sort of comforting for the system, I think, is the work that you've led over the last few years, Shane, on locality. So I would expect that we would be sort of ahead in our thinking already. You know, I understand that we're going to do some more engagement, but so I think that's a really good place. So just thanks for that update. In terms of elective, I'm really interested in the community diagnostic centres, and we did some work. We rolled something out, some out last year. I wonder if you can give us a feel for how they are working. So as a base level, obviously we need to build on that, but how are they working? Are they up to scratch? You know, is productivity as we'd expect, as a base before we then move on to more CDCs in the future? Thanks.
Thanks, Alan. Shane, I've got a few hands going up, so why don't we take the 5 that I've got already, and then perhaps pick up the questions. And I think, Ellen, that one on locality reviews, I'll probably pick some of that up later on the update on the ICP. But so I've got Fiona, Richard, Steve, and then Alison.
Thanks, Jeff, and thanks, Shane. Just a small point, but an important one, in relation to the development of the community health and the locality reviews. You didn't mention VCSE, but I know that you're actively engaged with us and you've asked for feedback. I just wanted to add it to the minutes that, you know, we are very much involved in that and very much part of that planning.
Okay, thanks, Fiona. Richard?
Yeah, thank you, Chair. Shane, really helpful paper. Thank you. Just to acknowledge thanks to everyone in the system for the efforts around the urgent care system over the Christmas period. It is recognised the lengths everyone went to look after our population. So thank you. 2 quick things from me on the elective. You referenced the financial incentives. I know our finance colleagues work very closely across the providers and the system. I think we need to stay very close on that and understand exactly what those financial incentives are and how they will play out. So just to flag that, but I know the teams are in touch regularly on that. And the other one's really an offer, Shane. We're working very hard to say, what does our support to a community neighbourhood health model look like? How do we work with you? So again, we just really welcome the opportunity of supporting your team. And if there's anything we can help broker as you take that forward, we're really keen to do so.
Thanks, Richard. If I take Steve and then Alison, and then perhaps pass back to yourself, Shane, and then come back into Maria, and I think Joe might be trying to put her hand up as well. So, Steve.
Yeah, thanks, Shane, and an excellent paper. Thank you very much. It's really packed full of the stuff that the ICBs, I think, were designed to start delivering on. So that shift and also the health inequalities. So that's really great to see. It's building on what Ellen was asking really around the diagnostic centres. We know that we're going to have to really invest in modernising towards community, and that does mean that we're going to have to work out how to do this across our system. And that might include how we start tapping into research funding. And I just want to put that on the map, that we know that the NHS is obviously tight for cash, but there may be research pilots that we can do that then allow us to move some of the dials, and let's work together to see how we can do that.
Okay, thanks, Steve. Alison?
Thanks, Jeff. Shane, really, really good paper. I agree with what Steve's saying about where we occupy this space as an ICB. Just around the elective care and the health inequalities. I mean, we've talked a little bit about this for some time. And I guess in one way, it's a question about how you manage our expectations as a board, because targeted interventions to reduce disparities in access to care, it would be quite important to understand what we would expect to see as a board and when we would expect to see it in terms of what that actually looks like in practice. So how we move from the principle to an outcome there. So maybe it's about managing our expectations, but I'm really interested in that. So thank you.
Thanks, Alison. Shane, why don't you come back in, and then I'll go back to Maria, and then perhaps we can move on. But over to you, Shane.
Yeah, in terms of CDCs, I think it would be helpful both Dave and Maria would comment. But I think what should be noted is from a performance perspective, we are exceptionally high in terms of performance for diagnostics as a system. However, the opportunity to do even more at a local level, and both CDCs are up and running. And Maria, you may want to come in, because obviously they were originally set up under the contract of NBT. So I don't know, Maria, you want to come in, but they are a fundamental part of the strategy, and we are very well placed by the nature of what we have. But Maria, do you want to just come in on that?
Yeah. So actually, at the 6th of Jan, as you say, the Reforming Elective Care paper coming out, and then coincidentally, we had Darren Jones from Treasury and our local MP come and visit last Friday to the Community Diagnostic Centre. So we are very well placed in SSG. We have 2 community diagnostic centres, both functioning, fully staffed. 28,000 extra appointments have already been delivered, and there are 40,000 booked in totality going forward, and we are able to offer a full range of MRI, CT, DEXA, endoscopy, X-ray, a fantastic array in people's local communities. Patient feedback has been incredibly positive, so these are really seen to be of value in the community. The other strand obviously is the surgical centre, which opens in May, where we'll have 4 theatres, 11 medi rooms and 40 beds. So again, incredible capacity, all additionality coming into our system. So in answer to Ellen and others' question, that's absolutely fantastic. Some other strands of the elective reform around patient-initiated follow-up, advice and guidance, etc. I would absolutely agree with Steve on some of the innovation we might want to put around that. Having come back from a recent visit to India, people leaving hospital with biosensors, with follow up in different ways, with avatars that give them advice on prehab and rehab while they're at home. There is so much we could be doing, and I know we are already doing through UE, UOB, working with Sanjoy and others there. I would also just confirm that in terms of diagnostics, very good as a system. NBT for the 5th month running, best in the country on DMO1 performance. So, a real tribute to what's going on in BNSSG. While I've got the floor, I will of course say while we're doing elective, the pressure on urgent and emergent care, the two do sit together. If we've got staff and focus going in one direction, we still need to keep an eye on the other. And I would just want to commend the incredible efforts of staff across all the providers over the last few weeks, and also to say a big thanks to the ICB for being so responsive when we were in extremis and knew we had to do something. Shane and the team and Dave pulling us together to really focus on making some short-term additional input that really just got us over a hump and allowed us to breathe again. We hope that will be enough, but obviously, we need to keep our eye. Flu has been a really big factor, and some of the infection control issues have really made it very, very difficult. So I just wanted to give an update in response to Shane's question.
Okay, thanks, Maria. That's really helpful, informative, and some brilliant work in there, isn't there? So Shane, back to you.
Yeah, so Fiona's point with regards to VCSE, Fiona, fine well, absolutely. It's and one thing we have to be really careful about is that any potential national guidance also pays due regard to the VCSE. Okay, and I've certainly tried to influence upwards on that as well. Okay, so it is really important that it does have that. Financial incentives, Richard, I couldn't agree more. This is the worrying part of moving forward in a financially constrained future year of 25-26, and let's be honest, we don't know yet, but public funding being what it is, how do we ensure an appropriate incentive to increase elective care? And it is one that you and I both know that our finance colleagues are absolutely all over this at the moment, because we want to incentivize more elective care for the benefit of our patient, but we have to do it within a cost envelope that is affordable to the public purse. And therefore there are ongoing conversations, absolutely. Steve, research one, couldn't agree more, and certainly through Joe Medhurst's office, what we do in research and BNSSG is magnificent. The opportunity in this world is enormous, so I couldn't agree more. And then with regards to health inequalities, Alison, we haven't yet defined how we will push this further. I think, and I'm conscious it's a public meeting, but I think there are some really innovative and brave systems in the country who are making decisions about waiting lists and places on waiting lists to enable people to have equity of outcome by putting them further up a waiting list based on the nature of their inequality. And it is an area I think that we should be exploring, and an area that we will be exploring.
Thanks, Shane. But that is a nice segue into the next item. And we talked about this at previous board meetings. Health inequality should be a strand that runs across all of our committees and everything that we do. But very often, like equality issues, that never gets the light shone on it in the way that perhaps it should. So Joe is going to talk next around the Health Inequality Committee and group that has been established. And you'll see later on in the agenda, there's an issue around the scheme reservation about the establishment of that committee. We absolutely don't want more committees, but I think already the signs from this committee are showing that it is absolutely needed. So unless there's any other burning issues for Shane, I'll pass over to Joe.
Thank you,
Okay, Joe.
Jeff. Thank you. So this paper and the terms of reference for this committee have been widely socialised. So I'm hoping board members have seen them. So I'm just going to assume the paper's read and just give a quick summary of the content of the paper. And I think this has been an evolution as we've developed into an ICB. And really nearly a year ago now, I sort of brought a little retrospective review of where we were on health inequalities. And there was pockets of really excellent work across the whole system. But what there wasn't was an organised, systemic way of looking at health inequalities as our wider ICS. And I think the discussion with the board in March led to, are we content? The first question, are we content with this method of improvement, this sort of evolutionary approach? And we weren't. And so I was tasked to think about how we make this more systematised, how we make it. And I was thinking it's like the stick of rock, isn't it? There's multiple things in that stick of rock, multiple layers, but at the core of that stick of rock, our commitment is to improve outcomes for people who suffer disadvantage and to improve health equity. And so this is right, this is the way that we all agreed to do that, really. And so we've set up this committee, the Strategic Health Inequalities Prevention and Population Health Group, which I will now call the SHIP. I do like a catchy acronym, but it's the SHIP. And I think it's quite a good metaphor, isn't it, about how we're sailing in a new direction and how we can lead that approach. So I like the SHIP for a number of reasons. And the group does have a mixture. So it is definitely about health inequalities and health equity. It's a place where we can start looking at our really good population health data with much more of a critical eye. And more importantly, taking that data and driving it into action. Because one of the things I worry about in this space, it can be quite intellectually stimulating to look, to analyse, to sort of empathise with it. But we need to do stuff about this. So this group, this has become a subcommittee of the board to really push us into stop observing and move into actions, review. And it may be that the actions don't deliver what we want, and then we'll go around an improvement cycle again. So it's a subcommittee of the board. It's a new subcommittee. I'm very grateful that Jeff did agree to chair it. I think having that really senior commitment to this topic has altered the conversations we were having and actually the seniority of people attending. So I think it's the right thing to do. And I can feel that move to action happening because actually we've got people who can make some decisions from across the system. We have 3 public participants who were interviewed and attend, who are already adding huge value, and that different lens into the dialogue, I think, is just a really helpful thing to do. We're starting quite simple. We've approved the long-term plan. We've got an absolute focus on cardiovascular disease. And the reason why cardiovascular disease is always the priority is it's the cause of the greatest mortality across our population. It's got wide disparity around people who are more privileged and less privileged. So we know we've got improvement there. And the data would tell us we could do something in that space within 3 years. So we're starting there. but we've also got the other long-term conditions we need to focus on. Diabetes will be next. Respiratory disease has got, we're not doing as well on respiratory as we could. But we'll also do things like sign off the joint forward plan. And actually the last meeting, and Jeff can comment, we looked at that, and our Tracy Jolliffe from the Independent Advisory Group noticed how predominantly there was no comment of race in this at all. There was no comment about racial disparity and racial injustice. So we'd missed it. And actually just having that, you've missed this again. It's like, yeah, we have. And so we did some action on that. So you've got the terms of reference. You can see the 2 meetings we've had. We're using sketch notes to try and give a summary of the work. And so we're trying to make the group a slightly different place and a different approach to some of our other subcommittees. But I'll pause there and take questions either for myself or maybe for Jeff if needs be. Thank you.
Okay, thanks, Joe. And just to say, perhaps before we move on, and there's a real energy in that group, and you can see it, and a real keenness to make sure it's action-oriented rather than just talking about everything. And Joe has talked about prioritisation. I'll come on to a bit more of that on the equality report as well, because otherwise we try and do everything and we do nothing. So there is an intensity in that group to do that. Joe talked about Tracy Jolliffe as the chair of our IAG. We're doing interviews this afternoon for other IAG members to extend that group, and there'll be more focus on that. But this does link into the next item as well around our res data and where we are on it, and I'm sure Joe will pick some of that up. But let me open it up to questions. Steve.
So I think this is just fantastic because it's core to what we should be focusing on, and in particular the whole piece of prevention measures, because that's what we need to be focusing on. My only comment at this stage is we're going to have to find a way of carving out some investment fundings somehow to support the initiatives that flow from this, because in effect we're trying to shift while still running stuff, and that's difficult. So we need to create the headroom so that the good work that comes out from this towards prevention, and then certainly around chronic disease management monitoring, how we find the headroom to be able to fund some of that, even if it's only at pilots.
I agree, Steve.
Steve, it's a really good point, and hence that's why, of course, my involvement with all the committees mean that we don't just have a financial contribution that neglects the issue around health inequality as well. But I know Joanne amongst the exec team will make sure her voice is heard. I've no doubt about that, and absolutely it is very important. I got Richard, then Fiona.
Yeah, thanks, Joe. We're really pleased to see this, but also to hear that message that it's everybody's business. So it's not about a committee taking it all, but that was welcome. We shared the paper with a number of experts in NHSE. The couple of comments came back really welcoming the focus on alcohol and tobacco addiction and also healthy weight. There was a curiosity about relative quietness on core 20+5, and just a sort of implied rather than explicit, I suppose, was the sense. So just to make sure that was covered. And then the other point colleagues raised was if the committee could really help with transparency on funding, it was felt that would be a really helpful space to be in, but really welcome the approach.
Yeah, thank you, Richard. On the core 20+5, we have agreed to go. We're one of the sites that have been chosen to do an evaluation of core 20+5, and I had that interview this week. There is a tension, I think, between having a really good set of population health data with quite a lot of detail and nuance, and the relatively, 5 key areas with binary interventions, and we're going to explore that with the team. So I can argue why that's not in here. It doesn't mean we're not looking at outcomes linked to ethnicity, race, deprivation levels, but we've got a really good population health data set that gives us much more nuance. So if I'm really straightforward with you, Richard, I'd say we probably moved on a little bit. So we're going to be part of that evaluation to put that a slight challenge into the team, because actually health inequalities and population health has got to be linked to the ICBs and the population we serve. It shouldn't be nationally mandated, I would suggest. So I'd like that discussion and that slight dissonance maybe to be played out.
Thanks, Joe. Fiona?
Thanks. And thanks, Joe. A really great report. I just wanted to articulate the support from the VCSE sector. We really value this space. We really value the conversations that we're able to have in this space and our contribution and being equal partners. You know, this is very much what we could describe as co-designing, which is just great. We've really valued the conversations around terminology and language, prevention. You know, what do we mean by prevention? It's not necessarily medical prevention, community prevention. What do we mean by community? And we've got obviously the conversations around neighbourhood. And I completely support what Steve has just said about funding. We've got some great ideas here. We know that we want to get into this space, but we do need it to be resourced. And I'll also pull in what somebody said about research as well. We've got some real good opportunities here to do some innovative work. So yeah, I just wanted to say how much we support it.
We've just rewritten, thank you, Fiona, we've just rewritten the research strategy. And again, we've pivoted it around the focus about equity, health equity and inequalities. So as that comes through, and that will be going to OPQ in the next couple of months, as it comes up through board, you'll see that the research strategy is now pivoting around in line with this sort of principles that's in this paper. So I'm trying to line up all these things so that they, you know, so they're synergistic rather than actually maybe being slightly at odds with one another.
Thanks, Joe. Dave?
Yeah, thanks, Chair, and thanks, Joe. Obviously, having led the previous version of this, I'm very supportive of this, and I'm really pleased that we've got it back in place again, and support all of the comments that have been made earlier. I know you appreciate this, Joe, but it's really important that we keep the work of this group closely aligned to the work of the Healthier Together 2040 work, because they need to work complementary together. And to reinforce each other, and I think there's a really fantastic opportunity if we can do that. But yeah, very supportive of it, Chair.
Thanks, Dave, and good point. Jacob?
Thank you. Really good paper. Just to really reiterate the point you highlighted and the risk around it being seen as a group that is taking on the responsibility for delivering sort of change in health inequalities, but actually the really important part is it helps us embed cultural change and principles for other groups and delivery groups to follow. And then just a comment around, so a lot of the wider sort of social determinants of health are outside the sort of control of healthcare, and just making sure that social care is fully integrated with this. So I can see there's public health or membership, but whether sort of a wider input from the social care side of things would be helpful.
Yeah, Joe, do you want to pick that point up on social care?
Yeah, no, I think it is, and I think through our sort of combination with the again, it's a balance, isn't it, Jake, about how many people and time. But we've got close links with the directors of adult social care, and again, close links with the directors of public health. But I'll make sure that we keep that close. It's a fair point. I absolutely agree.
Okay, thanks, Joe. Hugh, did you want to come on that?
Yeah, very briefly. I work very closely with Christina Gray, who's our DPH, and so to be fair, it's the kind of thing that we could either or both of us be involved in. So I am pretty confident that the DPHs are representing social care effectively. So it's good for me. I think it's extremely positive.
But it's always a bit of a tension, isn't it, here with that? And we just have to keep it under review and see whether it works or doesn't work. Because sometimes the DPHs think so it's something just to keep a little eye on. It's a good point.
Always
thanks,
got an eye on. Yeah.
Yeah. Thanks, Hugh. And I know Christina's very positive and optimistic about the group from the involvement she's had. And Jacob, you're absolutely right. It's a bit of a catch-22, isn't it? Do you have a shine a separate light on it, or do you have it as a golden thread, like I said at the start? Experience tends to tell me on issues like health inequality and what we're going to come on to as well around equality. If you let it be everyone's business, it becomes nobody's business. And we just continue to do the things we've always done. So I think it just needs an injection of change. That said, it has to have the read across. The points everyone's made, which is the 2020-40 and our financial projections, it all needs to knit together. Joe.
Yeah, and I think one of the things that triggered this, and it's going back to the point about what is our role within our different organisations. And you hear me talk about prevention. Are we leading? Are we partnering? Are we contributing? Are we advocating? And I think in a way, we've all been trying to be in the same space, to the point, as Jeff said, actually, we weren't then getting action orientated. We have got a suite of very significant metrics that come out of NHSE. We do an annual return, and we are expected to drive improvement on health metrics. And that is what we lead on. On the wider determinant stuff, again, it depends on your role, but the directors of public health will say, actually, you don't want to be coming in encroaching in my space, but I want you to partner or advocate for me. And that nuance about our interactions and our roles also then goes for that 2040 work, because that principle will apply there. So absolutely, health is linked to wider determinants of health, but a lot of health is also determined about, are you on the right statin? Did you have your blood pressure checked? And we've got to get our fundamentals right across our system. And I would say that when you look at the data, we're not quite there yet, and we've got improvement to do in our health. And then we can actually get into some of the broader. But all that's going to happen at the same time. But we do need to be aware of what we need to focus on around the delivery of healthcare and health outcomes across that health inequality space. And that's what this committee allows us to do.
Thanks, Joe. So as a board, we've been asked to do a few things. Rob, I'm looking at you on this one, because we've also got a separate agenda item around the reservation and delegation, the scheme delegation. But we're asking to do the recommendations on this paper are asking us to note the proposed changes to the scheme of reservation and delegation, and to formalise the committee as a subcommittee, and consider the SHIP terms of reference, which have been finalised by the group. So, Rob, we've got this as a separate item around the sword. So, can we deal with it on this item?
We probably can, and then just acknowledge it in the minutes that we've done that when we get to the separate item, because there is, of course, in the separate item a matter around the constitution as well.
Yeah.
So,
okay.
So Chair, absolutely. The conversation around the establishment of the SHIP committee, the board will be interested and want to agree its terms of reference. And I have done a housekeeping piece, if you like, with regard to the scheme of reservation and delegation. So I guess if the board endorses the terms of reference of the SHIP committee, when we get to it will also be saying yes, and I agree to the scheme of reservation and delegation, which then formally acknowledges the committee as a formal committee of the board, and that's in regard to our constitution.
Okay, lovely. Thanks, Rob. So can I check then? Are people happy for us to proceed as planned with the paper? Yeah, I'm not seeing any dissenting voices to that. So I'll move us on, if I can, then to the next item on the agenda, which is around equality, diversity and inclusion, and the update on that. You will have seen the report that's been circulated to you. It is quite lengthy. There's a lot of detail in there. I would start off by saying there is some progress. We are seeing some areas where we're improving. But certainly around, Joe will go into it now, around the pay gap, there's still some significant issues. And, a quarter of our staff are black and minority ethnic, but there is still some significant issues around retention, progression, and promotion for people in the system, and also the way that we are responding. So, Joe, over to you, and I'm sure we'll have a few questions on this one.
Thank you, Jeff. And colleagues, so Sam Hill, who is the author of this report, is on the call also. So thank you, Sam, for joining. I just wanted to highlight that this has already been through our People Committee. So a few members of the board have already had a chance to look through this in detail. And we had a lengthy discussion at our meeting at the end of last year. Very helpfully, also, Chair of our AAG, Tracy Jolliffe, has also had a look at this and has guided us in the way that we have changed our reporting as a system in relation to this work. So you, as Jeff has highlighted, you do already have a copy of the paper, and in the board paper we have highlighted a number of key areas that we just wanted to pull out, really the data, but also just a note on some of the actions that are being taken forward. So this paper covers the EDI activity for the system in 23-24, but highlights a number of the actions that continue to be focused on within our system. So although the data is for that year, actually the activity is live as we have the conversation today, and it does look at system and organisational level. What I would say is, just based on the last conversation, it is aligned to our strategic objectives. So we are really aware of the number of people people that work for us within our system, that actually making sure that we are thinking through and aligning with the tackling inequalities work, with the core 20+5 work. So the integration of the workforce activity in this area alongside the work of the committee and the tackling health inequalities work that we've just talked about is a crucial part. So we have brought those things together, and grateful to be working with Joe and Adwa and Sam in relation to meeting those strategic objectives through our workforce endeavours as well as through our service provision. As I've said, the full paper contains all the details of the areas, but I would say to you, we have gone one step further. So we are not required to report on the ethnicity pay gap. However, we have looked at that as a system, and we have added that into our reporting because, as Jeff has already alluded to, it does highlight some significant areas that we need to consider and address in the context of the conversation that we've just had. So really important addition. We felt a really important addition. Just a few key points I want to note really and to bring to your attention, and then we can open it up for discussion. In terms of gender pay and ethnicity pay, there is still work to do in both of those areas, and we still have there have been improvements, but we still have issues in relation to male-female split, as well as in a higher proportion of our racialised staff in lower to mid pay quartiles. We still also have a gender issue where it comes to part-time working, and we do have the same issue where it comes to part-time working at lower grades and very little part-time working seen at higher grades. So those are issues that we need to tackle and to focus on, and we do have actions that are taking those forward within our organisations. In terms of our res data, as Jeff has alluded to, there have been improvements in many areas. So we have seen a shift in terms of our shortlisting, which is something to be considered good. Also, the data around our bullying and harassment, the take-up of training, though we have seen improvements in those areas as well. We haven't yet converted the shortlisting to appointments, so that's something that we do need to focus on, and our inclusive recruitment system endeavours and organisational endeavours are working hard to tackle that. So that is something that we will keep an eye on as we report now for 24-25, and we start to gather that intelligence. And likewise, there is work to do around disciplinaries and capability. So it is more likely for our racialised groups to be taken down a disciplinary route. So we do need to dig into that in more detail as well. That is mirrored, unfortunately, in our disability data also. So, and here we are not doing quite so well. So all areas here are underrepresented against our community figures. We have an endeavour, it's a strategic objective that we align our workforce with our population. We are not there yet. And certainly when that comes to our global majority workforce, but also where it comes to our disability workforce. So more likely for colleagues who are registered disabled to also enter capability processes. So there is a large agenda where it comes to our disability data and how we're supporting staff in those areas. So there are a number of other, there's a lot more data in the report, but I just wanted to highlight also, I guess, which is, I guess, a risk as far as we're concerned, and that is that there is resource that is obviously put into managing this. It is limited. It is limited across all of our system providers. So we do have, I'm pleased to say, a really active, highly engaged system EDI group. That includes all of our partners. So our local authority colleagues are also part of that. And that actually is a group that understands its agenda, understands how it links to the wider picture, and is working hard to take forward many of the actions that are detailed in this report. But it is a small resource, so we are aligning it alongside other people professions, and we are aligning it alongside our training and development colleagues. But it, as I say, it is a risk to how much we can actually do, in year. I wanted to just publicly also put on record that massive thanks to Sam Hill and Callie Hutchins, who have changed the way that we are reporting our work, not only as an ICB but as an ICS, and this board report is the output of that. And actually, we have been asked to share that with other systems because it has been looked at externally and has been held up as good practice. So I just wanted to highlight that and have that minuted, that we have that recognition. So I'll stop there. Sam is on the call. We can answer any questions, but grateful for a discussion about where we find ourselves. Thank you, Chair.
Okay, thanks, Joe. Any questions or comments from board members? I can't see any hands yet. Just a couple of points I would make, Joe. I think the first one is big thank you to you and Sam and others, but particularly the two of you in the way you're pulling this together. I've been asked to take on the regional lead for Equality, Diversity and Inclusion from Patricia Miller, who's the Chief Executive in Dorset. And we are in a very different place in BNSSG to other places. So it is a congratulations to people on that. However, Joe has highlighted a lot of things in there, which is you're more than twice as likely to be appointed if you're white than if you're black or minority ethnic. And that's just one statistic. So the point being is what are the things that we as a board, because we're different across our organisations. If you look at the data across our organisations, it does significantly vary. And some organisations might be talking about smaller numbers of people than others, but still the statistics speak for themselves. So I would just pose that question of there's a lot of activity going on. This shouldn't be activity for our Equality, Diversity and Inclusion group. It should be for all of us. It's not for them. It's for them to advise us and for us to do the doing. I know we all know that, but I think the challenge back to us as a board has to be about, okay, what are the 2 or 3 things that we at BNSSG want to be known for, are the things that we really want to push hard on so that we can see a difference as a board. So I can see a lot of hands going up. Let's take them in turn, then go back to Joe. So if I take the 4 hands that are going up, back to Joe or Sam for a response. So Alison, first of all.
Thanks, Jeff, and thank you, Joe and Sam. I think this is a really important report and it's got such a lot in it. I guess the question, just thinking about Jeff's challenge back to us about variation, one of the things that comes through is the consistency around disability and organisationally where people are happy to declare whether they're disabled or not. And it always strikes me that that's not a technical transactional thing. Potentially it could be a big psychological thing, a cultural thing. So because those figures, as you rightly pulled out, Joe, aren't great either. So what is it that, because it isn't just about someone saying, yes, I have a disability, this is what it is. What makes them uncomfortable? What makes people not want to say they've got, or so I guess it's understanding what work we could do across the system around it being safe for people to be who they are and to say whether they have a disability. And then we then need to improve the statistics about how we appoint them and how they don't go through disciplinaries more than others as well. So it just felt a cultural thing across all the providers and us as an ICB. So just your thoughts on that would be quite helpful.
Okay, thanks, Alison. Ellen?
Thanks, Jeff. Joe and Sam and the team, thanks very much for this report. Some really fascinating sort of data within that for us to work from. Joe, you mentioned a small resource to focus on EDI centrally. So Jeff just said it's everyone's responsibility. I think the pay gap ethnicity highlights that we've got lots of work to do, plus what, Alison just talked about disability. How are we using some of these tools within development plans for sort of our more senior managers in the organisation and across the system, and then down through to middle management? So again, Joe, you and I and Jeff will have worked with the Welsh Government. A lot of work has been done in this area, and I just wonder how we are bringing that into development reviews and that sort of thing. Thanks.
Okay, thanks, Alan. Fiona?
Yeah, thank you. First of all, Joe, just appreciate, like everybody else, how much work has gone into this report and all of the analysis. It's brilliant. I'm going to pick up on Alison's point, because I was going to say it as well, around people reporting. and the confidence of reporting. And in our experience, people don't feel that they can report disabilities or difficulties in fear of it jeopardizing their employment. So that feeds into culture. I did go looking in the report around culture, and I didn't see a great deal analysis around the culture of the system. But just being a critical friend from the VCSE sector, it is a very hierarchical culture. It's very much command and control. And I know that, you know, there are reasons for that, but maybe if we can look at a shift in culture that is builds confidence and is more supportive, we can because our greatest asset is our workforce, and we can't deliver anything unless we've got our people. So how do we look after our people? And the other thing I just wanted to flag is asset-based community recruitment. And Wellsprings have done a great piece of work around asset-based community recruitment. Again, our people are our greatest asset. There are a great many people in our communities that would be brilliant in employment in the system, but there are a great many barriers to them getting employment in the system. So maybe if we look at recruitment in a different way, that would be great. But Joe, fantastic work. Thank you.
Okay, thanks, Fiona. Let me take Ruth and Deb, and then I'll come back to you, Joe.
Yes, at risk of being boring, I would add my thanks to everybody who's produced this report, because it is a fascinating and insightful read. I guess my reflection is that general practice and wider primary care are not very well represented in the report because of lack of, not through want of trying, I'm sure, but we do have difficulties with the data availability for that. So I think maybe I would ask that we do think a bit more about how we can get better data from our primary care workforce so that we can make sure that we've got the same level of insight into that, because it's a significant chunk of our overall health workforce.
Okay, thanks, Ruth. Deb?
Yeah, I'm sorry, I'm going to continue the theme. I think the data that's in the report, Joe and Sam, is really helpful. It's the first time we've seen this collated together for our system and been able to see some of the benchmarks. So that kind of helps us, that benchmarking stuff helps us to be able to go see where to look, to see where we've got some great practice. I think the bit about that Ruth's flagged about, have we got all the data yet? And then I think it's an offer, Joe. How can we work to try and make sure that with your indicators, we can turn this into, you know, a single dashboard that we can actually start to look at much more easily? So I'd like to make that offer from the SI team, that we work with your team to think about how we might create something. And then just one final question, if I may. The voice of the network. So I'm just checking the three things that we're focused on. Are those the three things that the collective networks want us to focus on, that they think will have the biggest impact on the areas of deficit, or are they more corporately agreed?
So Steve, I'll come back to you in a second. Let me go back to Joe, because there's quite a lot in there. That's a really good question, Deb, isn't it? Because that's the whole essence of our IAG, which is, do we shine the light where we think it needs to go, or where actually our public and patients think we need to go? The other one that you raised there around the data, this is data that has been around for a long time, most of it. We've collated it in a different way. We should all be very familiar with it, and I suspect we're a lot more familiar with other performance data than we are with this data, which probably says something. So Joe, back to you, then Steve, and then I'll go to anyone else who wants to raise any points.
Thanks. So a couple of things, and I will ask Sam to add some detail on the network voice. I would like to say I hope so. I suspect it's a bit of, you know, it's sort of amalgamation of the two, but I'll ask Sam to add more detail to that, because Sam and Callie talked to them directly. I'll bring Sam back in a moment. The dashboard would be really welcome, Deb. We have, however, asked for a number of other workforce dashboards, which have got, if I'm honest, a higher priority at the moment, which are related to our workforce numbers and our temporary staffing and our operational elements. So it is on the list of things, but your team can only support us so so much. So actually, if we can get there for the 24-25 reporting, that would be great, which will give us a few months to do that. So hopefully we welcome that. I just work backwards through the comments and then bring Sam in. So Ruth, on primary care, we have extrapolated as much as we possibly can access. So you're absolutely right, there is a need for enhanced data in primary care, and our anticipation is the same issues would surface, especially around some of the comments that have been made around culture. So there is more work to do in primary care, and again, as we develop the dashboard, we can work with yourselves, Ruth, and others in relation to accessing that more primary care information. To Alan's point and Alison's point and to Fiona's point, I guess, which all linked to culture, or all linked to the psychologically sort of safe approach. Organisations are aware of this. There are development programmes for line managers in place. There are support programmes for staff in place. There is a large wraparound around pro-equality and around inclusion. The policies all exist. So we have all the pieces of the puzzle in play. It's actually, though, how do we change the experience of staff so that they see that those elements that are there within organisational life actually support them. So that is work in progress. I think the idea of culture is very useful. We will take that back to the EDI group, because we haven't done a cultural audit, and whether or not a cultural survey. Our staff survey results are due out. They will give us some intelligence into that, but actually a focus of a strand on culture would see this report enhanced. So, and as I said to you, we are looking to enhance this year on year. So thank you for those suggestions. Sam, is there anything that you want to add to that from your conversations locally?
Yeah, a couple of things. I think one around development plans and being really clear that the high impact actions that are a requirement of delivery, certainly across NHS employers, talk about leadership and making sure that this is embedded within the core objectives of our leaders, and that is certainly something that organisations are saying is happening. So I think the next step is how we feed that through a wider the more extended leaderships across our system. The other part, just linking to culture, is to recognise that a lot of this also feeds into the wider people promise work that the teams in again NHS organisations doing, and we do have some people promise exemplars across the system. So I think it's making sure that we're linking those works together. And then finally, in terms of voice of networks, I concur with Joe. I think it's a bit of a mixture. So certainly our EDI leads work very closely with the networks in individual organisations, and my colleague Calais has a system-wide network, and the things we're hearing do absolutely feed into this, particularly around recruitment and the challenges that certain people within our communities face in even getting through our recruitment processes, and then their experiences once they're working within the organisation. I think those were the bits that I just wanted to add, Joe, if that's okay.
Thank you, Sam.
Thanks, Sam. Thanks, Joe. Steve.
Thanks, Jeff. I guess my question is, I mean, the paper is tremendous, just in the way in which it's presented, and you've got lots of data, but there are some gaps. There'll always be gaps. And what I'm interested in is, how do we, from an ICB perspective, how do we then work with organisations? Because this is everyone's business. And it's how do we make sure that we're tracking the progress being made in the individual organisations? Because that's where the cultural and behavioural shifts will happen. Otherwise, we'll keep looking at the data going, oh dear, or that's good, but we're not necessarily. I'm interested in how we link it and join it up and learn from each other, because this is a huge job. It's bad enough in my organisation. When I look at my organisation, and I've only got one, this is a significant agenda for the whole of the system.
Steve,
so
I'd be interested in your views on that, and then Joe's, because when you read the report, some organisations stand out for positive data, and some stand out for not so positive data. Now, do we deal with those in the board as a board, or do we deal with those elsewhere? What is our locus to do that with individual organisations? I suppose there's a lot of questions in there, Steve, isn't there?
Very complicated, and in the end, the organisations themselves have to own it. We can, my view is, maybe we can act as a bridge, a broker, to identify where best practice is, and then get some buddying going on, shared learning, almost like learning sets, if you like. But I do think this is a really complicated space, and it obviously will provoke all sorts of reactions. But the organisation itself will have to be central, is my view.
Thanks, Steve. Joe?
So what I would say is a couple of things is that actually our organisations are really willing. We are not pushing at closed doors here. So that is really that is something that has come and has developed, if I'm honest, from a ICB perspective, that galvanising the network, galvanising the organisations across all partners has been really encouraging. We have been able to identify what is happening in each organisation, and it is different, Steve, because different organisations are focusing on different priorities. We have had a really good system-based example on where we have drawn learning from other systems and from other regions, implemented the inclusive recruitment approach, developed it collaboratively, co-created, co-designed, learned from elsewhere, and it is now starting to help with the shift. That's part of the shortlisting, but it's also in terms of the cultural changes, line managers being trained in a different way, having different conversations at every level of the organisation. And that so where we have put our collective effort, we are seeing good outcome. It's about actually what do we pick, where do we prioritize, because there is a significant amount to do. It's too much. So actually, what lens do we go down? And we chose inclusive recruitment because actually that was a common issue across the majority of our organizations. But the network is the place for that shared learning and that areas of good practice within our own system. It's also the place where we would hope to create the space for that network to look up and out, so that they can actually bring in also good practice from elsewhere, and we can endorse it and then help organizations to implement it. So in terms of the method, we know what we have to do. We have a really good example of when it works and when it works well, and now we've got to spread that and scale it. And there lies the challenge, because this is a small group of people. So the fact that the overriding message here is that this is everybody's responsibility, and that actually we need to connect it into everything that we do, as we do with the health inequalities work, because Joe is on the same drum from that perspective, is the way that we need to shape our behavior and change how we deliver. So good examples, but absolutely more to do, but we need to prioritize where we put our collective effort.
Okay, thanks, Joe. I'm going to bring Shane in a second. Perhaps it's going back to where I started with, which is we are in a very different place to others in the Southwest, and perhaps some others across the country as well. So there's some really positive things here. The fact that we're talking about this in the level that we are at this board says something about our commitment and who we are. There is more to do. And just before I come to Shane, perhaps back to Ruth and to Jacob, which is, we haven't got that data around primary care. I know that can be onerous sometimes, but it will give us a truer picture about what's happening within primary care. So I just some advice from you really about how we might go about that. But Jacob, if I come to you first, and then I'll go back to Shane to conclude.
Thank you. So as you say, so it's really helpful to see this data there, and I guess it's about the trajectory. How do we know that the measures we're putting in place are effective, and how will we know when we've been successful or have got there? So I think it's about putting some marks in the sand about when are we going to review it, and where would we like us to have got to, and over what timescale. So being a bit sort of firmer on the outcomes to check, so that we can check that what we're doing is actually working. With regards to general practice, so as most organisations employ less than 250 individuals, it's not mandatory for us to report this, which I think is why the data isn't as robust. I'm sure there is the willingness and want to be part of this. And I think I'd be open to support from the system as to how we help practices with the resources to do this and the way to collect this information. So an interested and open offer of support, please.
Okay, thanks, Jacob. Joe, I'm sure you'll come in on this. I think on measurement, Jacob, the national res data does give us a trajectory, but the only real demonstration of change is where people who are minority ethnic or have got health disability or whatever it might be, whatever protected characteristic is, start saying we are a really good system in the way that we deliver people. So some of that narrative is really, really important, because we can produce as much data as we like, but if people don't feel it, then it doesn't really reflect the way we deliver our services. And I think Joe has touched on this. This is about our culture within BNSSG and about who we are as much as about what we do, so what we stand for. Shane, I'll bring you in as the final point, and then I'll move us on if I can.
Thank you, Jeff. So I was going to raise a point on primary care, and Jacob, thank you for bringing that in. I think it is important, as you say, statutorily, not a requirement. Is it the right thing to do? Yes. And therefore, how can we help as a system to help GP practices, One Care, GPCB to try to change that? So I'm more than happy the system does that. But the reason what I wanted to raise, Jeff, is this is an interesting thing about what's the role of this board and what's the role of organisations. Okay, so the job of the ICB in this particular space is to coordinate, to be a catalyst for change, and to try to add value. This board cannot performance manage organisations in this system. It's their duty to be doing this. It's their duty to be doing this. And therefore, I think it's important that there's so much we can do as a board, but I have no doubt every chief executive of our partner organisations own this. And therefore, the board, the question I would have from this board to our partner boards is this the kind of conversation that partners are having at their board, and what plans do their board have to improve it in their organization? Because I think we're going to have a coordinating factor here, which is great, but ultimately, we also need to know that individual organizations and individual, One Care, local authorities, and our healthcare partners are managing this locally. And only if we've got both of those can we start to see the shift. So we have a role to play at this board, but there's a big, big role to play in partners as well. And I have no doubt partners know that and are attempting to do something around that.
Shane, I think you're absolutely right. We all have a legal duty around these issues, but this is about leadership and culture. And we're not going to direct leadership and culture from an ICB. That has to be about individual organizational responsibility. However, by actually presenting it, looking at the data collectively and doing some comparison, it's a wake-up call for all of us about the things that we should be doing. So you're dead right. This is not about waving a big stick at people. It's about trying to get us to be working much more collaboratively, collectively, and in a culture that is embracing across BNSSG. So yeah, thanks. Joe, final word then, and I'll move us on.
Thank you. So Jaya isn't here, but who obviously chairs our people committee, but I just wanted to flag that actually through the updates that we seek from the non-executive directors of our provider organisations, we do ask the question regularly about this agenda. So we are conscious about how we loop that back in through the people committee. So I just wanted to represent Jaya and her efforts here, Chair. So thank you.
Okay, thanks, Joe. The paper says discuss and approve, but I think it's much more discuss than actually approve. I mean, we have to do the national sign off for it that goes back to NHSE. So I don't think there's anything for us to decide on in the paper other than the discussion and make sure it's been aired for us at the board.
The approval is for us to publish, Jeff, because we do have to put it up onto our website. So yeah. Thank you.
Okay, and I'm guessing there's no dissent with that from board members. Okay, we've got 3 other items. The next one that Dave's going to lead us through, then the next 2 should be relatively short. I'm going to suggest we had sort of a 5. We're not ahead of time, but I suggest we have sort of 5 or 10 minute break and then come back to the committee updates to finish off, and then public questions. So, Dave, over to you around the mental health services review.
Okay, thank you, Chair. I'd like to introduce Neil Turney, who's the head of mental health and LD&A in the ICB, who's been leading this programme of work. Chair, I'm conscious of the time, but I hope you'll allow us a brief summary intro, because there's a new area to the board, and I think it's really important that we openly share where we are with this programme of work. So I hope
Dave, it's really important, so make sure you spend the time on this. There's a lot in this.
Thank you. Okay. So members, this item is an update for the board on a review of intensive and assertive community mental health services for people with severe mental health challenges. The detailed review that you can see in the papers took place over the course of last summer, very closely with AWP and alongside BSW ICB as well as working alongside the voluntary community sector, people with lived experience, general practice and local authority partners. So really wide stakeholder engagement in the development of the review. These reviews have been requested nationally through NHS England, and I can see Richard's commented on the chat before he left about NHSE's view of where we are, and followed the tragic events in Nottingham in 2023. And the reviews are here to enable us to identify and then support required improvement. So all ICB has been asked to discuss these reviews and then share publicly where we are with those. We were aiming to do that in December, but obviously we've nudged that slightly to this month for reasons we all well know. Also to note, this review and progress was discussed and shared at the Mental Health and Care Improvement Group on Monday, which I chaired on behalf of Dominic, which is part, as you can see from the paper, the ongoing governance. So this is an absolute priority area for us and NHSE. Will continue to be an area of focus for us. And I'm going to ask Neil, Chair, if that's okay, just to walk us through the key points of the paper, so the board is very clear on where we are. And we're asked to approve the work that's taken place, identify key gaps and support that ongoing work. We want to be absolutely transparent and open with where we are and where next. And just before I hand over, I'd just like to thank Alison for input and comments to date ahead of today. And I know it's had an opportunity to talk through with Neil to clarify those points and hopefully drawn out in what Neil's about to say. Neil, I'm just conscious of time. So just thinking maybe just talk as opposed to putting any slides up, if that's okay, and really just draw out those key points. But Neil, before I hand over, just thank you for you and the team for the work you put into this to date, and over to you for those key points. Thank you, Neil.
Thank you, Dave. Hopefully everyone can hear me. So good morning. I was just going to cover, Dave's covered quite a bit already, but I'll go a little bit into the background, the process and approach, and submissions that we've made. Look at some of our areas of good practice, and a little look at the improvement plan that we've identified, and then talk a little bit about work underway and next steps. So in terms of status, the background, this review began at the end of July. All ICBs were instructed to review their intensive and assertive community mental health provision. We were given until the 30th of September to return our findings. And as Dave says, this follows the events in Nottingham. Is really about the need for services to be able to effectively engage people who may disengage when they become unwell, and where this could pose a risk to themselves or particularly other people. So the review have got two key purposes, and the first is to provide ICBs and NHS England with assurance that our services are meeting the needs of our local populations, and secondly to support NHSE future planning, policy and investment areas. So it's been a requirement of NHSE that all ICBs discuss this work in public through their open boards. NHS England gave us guidance in how to undertake the review, and the reviews were aimed at a priority group of individuals rather than any particular service. So that full list is within the paper. It includes individuals who present with psychosis, who may struggle to use routine services, who may be vulnerable to relapse, individuals who may also have social needs, housing, financial, self-neglect, and may often have co-occurring problems such as drug or alcohol use or dependency. It's a group of individuals who may have had negative experiences of using services previously, especially statutory services, and as such we took a really wide and collaborative approach in seeking the views of all services that could work with individuals within this scope. So we found areas of good practice which were included in the paper and things that work really well locally. Our early intervention services work really well with smaller caseloads and are able to offer a variety of interventions to effectively engage and support people. The AWP Rose recovery teams were recognised as being able to offer highly personalised support for people from our most marginalised communities. Our links teams bring together professionals from across services who support people who are street homeless or at risk of homelessness. Bristol City Council are well underway with their Changing Futures programme and the My Team Around Me approach, which is a multi-agency approach supporting people who experience multiple disadvantage. And within the voluntary and community sector, St Mungo's ACE service was recognised for their approach to working with diverse communities in Bristol. So the review itself found 11 areas for improvement, and the themes and specific areas identified to be improved are forming our action plan to ensure that our services can meet fully the needs of our local population and specifically the group of individuals in scope for the review. So we're going to go through more the process, and the paper kind of goes through what we've done to date rather than a current look at our action plan, but work is underway and developing to address the areas identified in the paper. AWP have, for example, now developed a project structure and a project group to progress the work at pace. They've begun to work to identify the policies that require review. They've updated guidance for non-concordance of medication, started initial voluntary community sector engagement to discuss caseloads and weights, and their business intelligence teams will be prioritising in January, work into a deep dive into people who previously did not attend data and non-engagement analysis. We are expecting to give feedback on a regular basis to NHS England on a sort of 3, 6 and 12-month cycle. And in terms of next steps, so we've taken this work and our approach through our local system groups, both the Mental Health Operational Delivery Group and the Health and Care Improvement Group, as well as working with the AWP Enhanced Quality Oversight Group. And we'll continue to approach this as a system, both at senior levels, but also operationally, and with people with lived experience as we develop the improvements. We'll continue to take an open and honest approach to the work, and that's worked really well in allowing us to identify the breadth of improvement and not adopt a defensive stance, and that's underpinning our ability to make improvements as a system. That will recognise the role of the VCSE can play in providing and supporting engagement with these individuals. On a practical level, we'll now get into the working through the action plan and providing that assurance both locally as an ICB and back to NHS England. As I said, we're expecting to report on 3, 6 and 12 monthly intervals. And NHS England recognise the task. It's not about a single team or a service, and we expect this to be an area of focus for the next 12 months at least. To support this, NHS England are developing a peer learning approach and a community of practice, and that's only just starting to sort of be developed at the moment. But that will support ICBs and bring consistency in this service area as well. In addition to that, NHS England are developing new national guidelines to inform service models in response to some of the existing good practice being over 10 years old. The board is asked for any comment and to continue to support the work, continuing through both our local governance and through the system executive groups as required, so that we can continue to provide updates on progress and the insurance to make sure we've got services in the place that they need to be. Thank you, Dave.
Thanks, Neil. Dave, anything to offer before I put out the questions?
Okay, no, Neil, set that out. Thank you, Jeff.
Okay, Neil, big thank you. There's an awful lot of work gone into this, and you can see reading the paper, there's a lot to digest. I'll open it up to questions, though. Dominic first.
Thanks, Jeff. And mine is more in the realm of a comment and a narrative, really, than a question, because obviously, as the Chief Executive of Avon Wiltshire Mental Health Partnership NHS Trust, we have a really big stake in this on behalf of the system. And if you'll indulge me for a very short while, Jeff, I'd like to give a long-term historical perspective on the problem that we're trying to solve, because that then informs what we might want to do moving forwards. And one can pick a start point, but I'm going to pick as a start point 1999, when Britney Spears was in the charts and we were preparing for the Millennium Bug. That was my main job in 1992. Under Tony Blair's government, the NHS issued something called National Service Frameworks for Mental Health that were implemented across the country, and they standardised models of care delivery, and we had to have fidelity to those models. And one of those was this thing called assertive outreach, which was a model for looking after these people, both supporting them in their lives, but also preventing them being a risk to themselves and to others. Those were implemented in the noughties and practiced very widely into the kind of mid-teens. But two things happened to call those into question. One was the Lansley reforms of 2012, which said we don't want nationally driven policy, we want local decision making and purchase provider splits and that sort of thing. And therefore there became almost a cacophony of different models across the country. But the second and perhaps more germane point is that an evidence review of assertive outreach concluded it was no better than any other models. And therefore the question was, so what do you do? And therefore people evolved to a variety of different models, and we evolved to different models. In fact, we evolved to 6 different models because we had 6 different CCGs and they had 6 different ways that they wanted to do it. Rolling forward through COVID and to now, this is a really helpful stock take of where we are and what we need to do. And as I hope the paper shows, we're not an outlier. There's loads of good practice. But my take is that what we're doing is necessary but not sufficient to address the needs of these people in the way that we would really. And the gap is either national direction to say you should do it like this because that's what the evidence says, or we're not sure what the evidence says and it might be driven by local context, therefore you should set your own strategy in this area. And either is fine, but what we do need is directions to which of those two things to do. So at the moment, we're having what psychiatrists would call a watchful wait to see what happens nationally. And if something doesn't happen nationally fairly soon, then I think what I, as the co-chair of the Healthcare Improvement Group for Mental Health, Learning Disabilities and Autism, would recommend is that we set a local strategy around this area and then do the gap analysis and figure out what we need to do. Because there remains a risk to this day for us and every other system in the country that, and I can't think of a softer way of saying this, so I'm just going to say it, a valgo-calocane could happen here on our watch because we do not have everything in place that we need. So I hope that's a helpful perspective.
Dominic, that's really useful to set the context around it. So I think that's hugely helpful. So can I open it up to questions? So I've got Deb, Ellen, and then Alison.
Thanks, Jeff. Neil, thank you. Really helpful report reflecting the points that Dominic's made about how critical this is. Just noting in the report from NHS England and the lessons learned with all of these untoward events, it's all about communication, continuity of care, gaps in information flowing between professionals. Just there isn't really much in here around digital, and particularly I'm thinking about connecting care as our shared record. I know you've got some things around local data sets and population health, which is useful, but I'd probably suggest that we probably need to look at how do we leverage all the crisis plans are in connecting care. It just might be good to see how we leverage that as one of the biggest investments we make as a system. Just make sure that we're not missing opportunities to utilise that better.
Okay, thanks, Deb. Neil, let me go to Ellen and then Alison, and then perhaps come back to you. And I think that one's fairly straightforward, but Ellen.
Thanks, Jeff. Can I just thank Dave, Neil and Dominic for the paper and for the information you've just provided. And also Alison, I've had a couple of communications with Alison, who was, as Dave mentioned, put some really good scrutiny and challenge through to the paper. Dominic, your perspective was particularly interesting there, and understanding that national and local perspective, but it's important that in the meantime we make some progress. And my question is about, I got a number of questions, but I just focus on this one. Are there any immediate concerns, Neil, that have come up from the review that suggest that we need to take immediate action on anything? So that would be my question, because this is obviously a long piece of work. You've talked about sort of 3, 6 and 12 months reporting, but there might be sort of certain concerns that we need to sort of sort in the short term. Thanks.
Okay, thanks, Ellen. Neil, I'll come back to you in a moment. Let Alison pose her points, and then perhaps we can come back in.
Thanks, Jeff. Thank you, Dave and Neil and Dominic. Really useful insight from you. Actually, I thought that was really helpful. I mean, it's clear there's much time, thought, engagement, expertise has gone into this, and it does give us a clear picture. One of my points was around risk and the risks that have been outlined in the paper, and maybe are emerging risks or risks that may not have made it to the paper. And Ellen's picked up one, which is, I think, when you look at the improvement plan, being clear what is a short-term immediate action, what's a medium-term action, and what's a longer-term action. But I just wondered whether we could, as a board, understand what the risks are that you think are at play for us to deliver the improvements we need to and make it safe for this quite vulnerable cohort. Thank you.
Thanks, Alison. Neil, do you want to come back in? I'll bring Dominic in if need be. But so as the points around the data that Deb has raised, and then the immediate concerns as Alison and Ellen have drawn out.
Yes, thank you. And I'm sure Dominic will have a sort of more informed view than myself. I think in terms of Deb's point, we can take that back and put that in the lessons, the areas for improvement sort of shared in the paper that needs to translate into an action plan with specific actions. We can look specifically whether we've got digital sufficiently covered. So that's a really good point. I think in terms of Ellen's point around the progress, when we were asked around the assurance, we were given a binary yes or no. And as looking at the review findings, we came down on the side that no, we were not assured. I think different ICBs have interpreted that differently. I think we think locally we've made the right decision based on the severity of what could happen and the fact that we were only asked a yes or no question. I think from my point of view, there's not one quick fix to be able to do this. That's why the areas that we've come up with are a range of improvements that all need to be delivered together to be able to make sure that locally we can treat people well, we can give them the quality of service, we don't discharge them that they disengage. So we've got effective ways to engage people who are prone to disengagement. So I think that is not something that we've been able to fix quite quickly, and is something that is being worked on at the moment. I think our assurance position is still partially assured that we've got things in place, but we've not got everything where we need it to be. The DNA analysis is not something that happens to everybody. It's something that could happen as part of a compound situation. And there's obviously a correlation around caseloads and weights and operational pressures as well that needs to be worked through. Did you want, Dominic, I'm not sure whether you wanted to say anything on that point.
Yeah, thank you for the opportunity to come back in. It's a slightly curious one. These are risks that we all have lived with for a very long time, and particularly in mental health practice. And I had a session with our consultant body just on this, just to have an open conversation about it before Christmas. That they articulate grave concerns about the risks around these patients, but they're not new concerns. They've always had those concerns because these are patients who present with very significant risks. So we to a degree, we sort of have to learn to live with that, I think. And we've taken a risk-based approach, and therefore we're reducing risk everywhere all of the time, and hopefully improving and getting better. I think in terms of the thing that might crystallize a risk, it's that, and people have heard this analogy before, it's the Swiss cheese thing. We know there are holes in various parts of practice, and if they align for one particular person and they all align at the same time, then you get the what they call the black swan event. So I'm mixing my metaphors, but that's the real risk that we're living with. And if you look at the reporting to valvocalocane, to an extent, that's what happened. Is something happened, then something else happened, then something else happened, or things didn't happen that should have done. And then when they compounded, that's what created the risk. So our ability to do dynamic risk assessment and evolve our approach to managing risk needs to become much better. But that, as Neil said, that's not a quick fix. So I know that doesn't give you assurance, but what it does is show you how we're managing the risk.
Yeah. Thanks, Dominic. Dave?
Well, thank you both for comments. I think the purpose of having it here is to identify gaps in our current process and to build on where we've got to. And Alison, so I think what we should do in the next iteration of our action plan is to kind of stratify our actions with clear timeframes for and implementation risks, and then Alison, as you've just said, more clearly detail those operational risks for each of the planned actions. So let's just thank you both for comments, but Neil, let's embed that in our next iterations of the plan moving forward.
Okay, thanks, Dave. Ellen?
Yeah, just quickly coming back, sort of Alison, again, very, very helpfully identified a governance gap, and it felt as if there isn't a board assurance framework for this to come through, and we would just, we suggested that it possibly comes through outcomes, performance and quality. And I just want to come back and just say I'm slightly uncomfortable that we've just had this conversation that we are not assured, and that many of these actions are going to take a long time. And I just think we should go back and reflect on that and just question ourselves on whether there is more that we should be doing at an earlier point. So that would be my only response that I'd come back on.
So Dominic, I'll bring you in a second. Dave, that was the point I was going to make really, which is the recommendations in the paper around the local action plan being monitored through the Community Mental Health Programme Board. It was that question around GRIP and reporting to make sure that we don't come here in a year's time and we end up with a horrible case. And we as a board have said, yeah, we saw that coming and we didn't do anything with it because that's just the way it is. Now, I'm not suggesting for 1 second that is what anybody has said. But I think Ellen's point there about reporting back through might be quite helpful to make sure that we just have oversight on how we're progressing. Dominic, and then back to Dave.
Yeah, I completely agree with Ellen's points, and I'm very happy, both as Chief Executive AWP and as co-chair of the Healthcare Improvement Group, to which Community Mental Health Programme Board reports, to be involved with the appropriate committee to do that. Really delighted to do that. The other point I would just remind people of, and I did say this in my sort of narrative, we're not an outlier here. Now, that doesn't mean we don't take it seriously, but it's not like, oh my goodness, we're terrible and we've really got to. We are. And I've had this conversation with the mental health chief executives from across the entire Southwest. Again, we had a focus session just on this. And we've all got the same issues, but with slightly different manifestations. And we're all struggling to rise to the challenge that we know is there and that we want to do better around. And we're not sitting here with learned helplessness saying, oh, well, there's nothing we can do, it's rubbish. But we're also not saying, haha, there's a magic bullet here, and if we just did this thing, it would solve the problem. So it really is, unfortunately, it's a question of grinding away at all the different facets of this to get a better model.
Thanks, Dominic. That's really helpful. David?
Just to say, Jeff, wholly supportive of that oversight through OQPM, but we wouldn't want to take that away from further assurance direct to the board as well at the appropriate time frame. So we'll, I think, really helpful to embed it in that governance process.
Yeah, thanks, Dave. Steve, over to you, and then I'm going to try and move us on if I can.
So just following on, really, this is such a difficult picture to get our heads around. I'd be more concerned if ICBs were saying they were assured, because there are so many unknowns that really I can't say that we would get assured. We get partial, maybe. We can control what we can control and see. That's the problem with this.
Steve, yeah, you're absolutely right. And this is years and years and years and years and years of issues, aren't they? So, you know, the fact that we're shining a light on it is helpful. And I think as long as we can see that line through, that'll be useful. Shane, and then I'm going to conclude if I can.
And I think it's really important that we cannot be assured that everything and all risks have been mitigated, but we must be assured that we understand the issue, we have an improvement plan, and we are moving forward with that improvement plan. Having had the pleasure of running mental health services and having some pretty horrible things happen, you are correct, Dominic. We cannot be assured of the safety of every single patient and others. But we must be assured we've got a plan, we must be assured we're delivering on that plan, and we must be assured that plan is having an impact in reducing that risk.
Yeah, thanks, Shane. I think everyone's saying that. So Dave, that line of reporting back through and oversight is going to be really important for us. But so thank you. I don't think it's anything on the recommendations we haven't talked about and agreed. They are all about the monitoring, they're about the updates, and they're about the communication. So unless there's anyone else wants to add at this stage. Neil, thank you. That's been really helpful. And Dominic as well for us giving us context around it. It's been really very, very useful. we got two other items that I think will be relatively quick. We got the one that is talking about the Constitution, and Rob, I don't know whether you're going to talk to this or whether Shane is going to, and then the one around the risk assessment or corporate risk register, and then I'll take a short break if I can. So Shane, are you going to come in on these, or do you want Rob to come in?
I'll start with the sword with the delegation stuff. I think it's really important. Very quick paper. Two things were changing: the SHIP terms of reference, which we discussed today, and then obviously with the creation of the acute group model. We used to have two members of our board from our acute, one representing secondary care, one representing tertiary care. Quite clearly now in the document we have amended that to reflect that Maria O'Kane is obviously the chief executive of the group model, and therefore Maria is representing acute services as its whole. I don't believe there's anything other that we need approval on, Jeff, and I just would ask that the board approve that change to our scheme of delegation.
Okay, thanks, Shane. I mean, that's pretty straightforward, but needs to come through the board. So is there any comments from anybody around those changes? No? Okay, thanks. Shane, sorry,
Jeff,
Rob.
Jeff, if I may, just for the board to note that the Constitution, as approved by this board, then needs to be submitted to NHS England for NHS England to finally. I've been doing the conversations in the background. It should not be an issue, and then I will publish it on the governance on the website.
Okay, thanks, Rob. That's helpful. Anything to anyone else? Shane?
No, and then the corporate risk register has been through FED. I don't know whether, Rob, you want to just raise that. It's been through FED, but Rob, just to highlight to the board anything that needs to be highlighted.
Thank you. So it's been through through audit risk and audit risk committee beginning of December. So as a matter of process, really, the corporate risk register is made available to the board. When risks are addressed, they don't just come off the corporate risk register. The board is advised that they can be taken back to being managed in the directorate. So you might notice that there are 6 of those on the corporate risk register, where it says that we're recommending that they're removed from the corporate risk register because the threshold is below 15, as per the risk management framework. They relate to leader completion, primary care prescribing, primary care data coverage, transfer of costs from social care, non-clinical contracts register. That doesn't mean that there are no risks in that area. It means that the risks have been mitigated sufficiently that they are now back for management within the directorates. There is one that is new on the corporate risk register, a risk around completion compliance activities associated with the Oliver McGowan programme, which has triggered cite by this board by virtue of being now above 15, and I'll probably stop there, Jeff, in the interest of time. But if people have got questions, obviously about specific risks, we have directors here who can hopefully field those.
Okay, thanks, Rob. John Capper can't be with us today, who's chair of our audit committee. So we don't want to do the job here of the audit committee, which obviously deals with the detail. However, it is important that board members are cited on the corporate risk register and have an opportunity to comment on those if they're not engaged with the audit committee. So, Ellen.
Thanks, Jeff. One sort of general question and one specific risk. Again, Alison and I have been discussing sort of some of the risks on the risk register, and there was one risk in particular that was related to the strategic risk register. So, Shane, just some guidance from you on whether we will be having strategic risk register here as well as corporate risk register, or are we keeping that sort of separate and just to audit committee?
So, strategic risk register goes through the system exec group and absolutely will come to this board, Ellen.
Okay.
And this corporate risk register, as you know, is about the organisation known as ICB, not the ICS, but both will come here.
Okay, great. I think we, as a sort of group of participants in this board, are probably just going through that process of understanding strategic, and I think over time we'll get used to a bit more. One specific, Rob, and that was on leader. generally will be supportive. However, we've had some challenges with leader performance over the last year. I know Rosie's put a lot of really good sort of stuff in place, but we've got outcomes, performance and quality in 2 weeks' time. So I would prefer to, we've got an agenda item on leader. I would prefer to have a discussion around the risk register of that item and then come back and perhaps remove that next time, if that's agreeable to you.
Ellen, I'm happy to take that steer, and I think that it's fair to say that there was a similar conversation around leader at the Audit and Risk Committee. Yeah. I followed up outside of the meeting with members of CNO Directorate. My understanding was that is exactly what was happening. It was being scheduled for conversation, outcomes, performance and quality.
So can we take that action for next board meeting then to actually remove that, if possible, from the corporate risk register? Just on leader.
I suggest that that's a very good idea, Ellen. Very good idea.
Anything for anyone else around the corporate risk register? Okay, I'm conscious we're due to finish at midday. What I'd suggest, if we just take 5-minute leg stretch just to give you a chance to regroup. It's 10 past 11 now. If we can join just after 11:15, and then that gives us just over half an hour to cover the update on committees and any public questions. So if people are happy with that, I'll see you back just after 11:15. See you all soon. Thank you, everyone. I think most people are back or are heading back very shortly. So I'll start going through the updates from our committees if I can. So starting with yourself, Ellen, and then perhaps pass to executive members to come in afterwards.
Okay, thanks, Jeff. Last committee, so this is Outcomes Performance Quality Committee. We last met on the 28th of November. I'm going to provide an update and we'll bring in Joe, Dave and Denise, who's here on behalf of Rosie, if further detail is required. Within the papers, under this agenda item, you've got the minutes, quality report, performance report, a report on winter plan arrangements, and importantly for today's meeting, a funded care commissioning policy, which is approval for the board. So it's gone through full scrutiny at the committee, but just needs approval from the board, and also the local safeguarding report. At the November committee, we discussed the areas I've just mentioned, plus performance and quality reports, a maternity and neonatal update. We had very helpful update from Shane earlier on general performance. We touched on urgent care and also on elective, and we also had Maria's very helpful update. So I think that's brought us up to date in terms of performance. There's 3 key areas to cover. First of all is a winter plan. So this was obviously back in November, so it was ahead of the winter that we just talked about, and Shane's brought you up to date with more recent events. In September, we had NHSE expectations of ICBs and providers, with a focus on 10 high impact interventions, such as same-day emergency care, flow, as examples. New this winter were care coordination teams working across primary care networks, focusing on keeping people at home and avoiding admissions. There was a plan for 20 in phase 1 with 10 shared administrators. At the next committee, we will be looking to review that to understand what progress and what benefit those presented. Dave, you've put your hand up. I don't know whether
Ellen, I was going to come in my update on that one. It is a point of accuracy from the slides.
Yeah.
Just to note, that was back in November.
Yeah.
And just to note, we've not been able to implement that scheme fully this year. We're still hoping to deploy elements of it through the rest of this winter. But I did want to note a matter of accuracy from what was presented at OQPM. So we'll be looking to fully mobilise and procure for next winter, but not we for a number of reasons not been able to embed that this year. So that was an update from me, Ellen, on that one.
Okay. So, of course, I'm sort of updating from the committee of the report that we received at the time. So, so thanks for that update, Dave. There also, after a review of previous winter, 4 schemes were identified as not being fully mobilised last year, which we did planned to mobilise this year, such as D2A, transfer of Care Hub, NHS at Home, and frailty and assessment coordination. I think importantly, Rosie and Joe were able to support winter in a clinical capacity through clinical involvement through a joint system quality group on health and care professional executives. So they were very much involved with Dave's team in working together to support the winter plan. We received this full report on the winter plan from Dave and Greg, including a plan for integrated care at home, and the committee provided quite a lot of scrutiny, challenge and support to the team over this. I just mentioned that we have our next meeting on the 30th of January. We will be looking to review the actions that were put in place for the winter plan. That's winter plan. In terms of the commissioning policy for funded care, that's included in the papers. The funded care commissioning policy outlines the process by which the ICB will commission funded care. There's not a huge amount of change, but the new policy reflects how the all-age approach is being implemented and ensures compliance with the legislative framework. The committee discussed the policy in detail, and we believed that the policy clarified some real grey areas and strengthen processes. So the committee therefore supports the changes and the recommendation for the board to approve the policy. So Jeff, can we just pause for a second just to agree and approve that policy? So it's gone through full scrutiny at the committee. We have Denise here or Joe who can provide answers to any questions, but can I just put that forward for agreement, please?
Okay, just outline again exactly what we're asking for, Ellen.
Okay, so the committee discussed, so there's a new commissioning policy for funded care.
Yeah.
The funded care commissioning policy outlines the process by which the ICB will commission and provide equitable, safe and effective care for individuals who've been assessed as eligible for NHS funded care. So the policy was there originally. There's been some changes, there's been some clarity, and therefore sort of those changes need to be approved by the board.
Okay, thanks, Ellen. Rob, is there anything to add to that around the specific at all?
No.
Okay.
Not about specifically that policy, but just that this is in line with the scheme of reservation and delegation, where the board is now cited, but the board must approve policies.
Yeah, absolutely. So any comments or questions on what Ellen's presented there? No? Okay, thanks, Ellen. Back to you.
Okay. Okay, and the final bit is that we had, which is I think very important, a full update on safeguarding. The committee received an update report from the ICB safeguarding team. Please report that the ICB, along with its statutory partners, has published its revised arrangements for its children's safeguarding partnership arrangements in compliance with the revised working together guidance. So sorry, a bit of detail there, but really important that we covered safeguarding and that we accepted a report in detail. The accountable officers from across Avon and Somerset Police footprint will now meet on a regular basis to discuss safeguarding issues at a system level, and then at a more local level, the children's safeguarding partnerships will work together through the local authority and at that level. Work continues to identify areas of joint working, led by Rosie, our Chief Nursing Officer, Chris Shivers on behalf of the Directors of Children's Services, and Elizabeth Hughes on behalf of Avon and Somerset Police. So basically, just to say, Jeff, safeguarding is an item that is taken very seriously, and it's on the agenda for every one of our committees. So sorry, a bit of a long update there, but it's important to cover those areas.
No, that's fine. Thanks, Ellen. So anything to add from exec team members? So Dave, Joe, or Denise? Dave.
Nothing for me. Thank you.
Okay.
Ellen did an amazing job in summarising the key points of the winter plan. Chair, and obviously Shane updated on the current position, and clearly we're now in winter and managing it as per the plan. I think the other point I just wanted to draw out in terms of our have the pleasure of leading a number of the kind of system engagement discussions or operational delivery elements of this has been that clinical engagement this year in our in our operational approach, as well as Joe and Rosie. We've also had significant support from the CNOs from across the system and our CMO. So it has been a truly kind of collaborative effort this year. So I just wanted to kind of draw out that, Shane, because I think there's been a key difference in our system development from this year to last year. I think Ellen covered all the other key points that I wanted to make. Chair, thank you.
Okay, thanks, Dave. So anything else then from Joe or Denise? No, Shane?
Just to make sure that people are aware, the local safeguarding partnerships, as Ellen described, all three local authorities and ourselves signed off our local safeguarding partnership plan for the year in line with the timeline. And now, as Chief Executive of the system, but also Dave, Joe, and Nick as Chief Executive of local authorities, and Sarah Crew as Chief Constable, we now meet in line with, so we meet at least twice a year formally, but other areas as well, to ensure that we are delivering on our local safeguarding plan. And a lot of work has gone into that via the three Chief Executive local authorities actually and ourselves to make sure that we have strengthened that process considerably now than maybe it was 12 months ago.
Yeah, great. Thanks, Shane. Any other questions for exec members or Ellen around quality performance or outcome? No? Okay, I'll move on to People Committee then. Jay is not with us, so Joe?
Yeah, thanks. So just a reasonably short update. So number of minutes are attached to the papers. We have had a subsequent ICS People Committee meeting in November. The main item was the item that we've had at board today. So our EDI, system EDI report. But two areas just to bring to your attention by way of update. Obviously, our monthly workforce monitoring continues, but a specific focus also on temporary staffing and the elimination of agency. So that work continues to be fruitful as far as our system is concerned, especially in the nursing arena. We're now moving on to other professional groups with the help of other colleagues, clinical colleagues, as well as the other chief people officers across the system. It is important that we bring a strong leadership voice here. However, we are very conscious that winter pressures are likely to have impacted this. We don't yet have the level of impact. We are monitoring that, and that will be brought forward now to our People Committee at the end of January and into February. The other item just to make colleagues aware of is that I have been working with the trade union chairs from across our system to re-establish our social partnership forum. The SPF was paused back in the summer because we had enhanced the people governance structures and wider engagement of our trade union colleagues into our broader people programme meetings, and that engagement and attendance will continue. But having had conversations with the trade union chairs and with my BNSSG CPO colleagues, we felt that re-establishing the SPF, where we focus specifically on collective issues and where we've got potential system solutions that we haven't yet uncovered. So we have had an initial first meeting of that reinstated social partnership forum, and we will set out a programme of work that brings together our trade union colleagues alongside our system priorities. So just wanted to highlight those two things in Jaya's absence, Jeff. Thank you.
Okay, thanks, Joe. Any questions or comments around People Committee for Joe? Okay, great. Thank you very much. Steve, Finance, Estates and Digital.
Thanks, Jeff. So the first thing to say is in your pack, you've got June minutes as well as October. That was a problem of us getting them to the last board. So you've got two sets of minutes. One of the things that we will need just to get approval for is the standing financial instructions were reviewed and approved to come forward to the board from that meeting for approval, and they are in the pack. So they're at 7.3.3 and they're the final version for approval. The main areas of change were to reflect the new grant agreement SOP, which solved issues that were already identified in a previous audit. So we've resolved that. And it was around thresholds of competitive tendering, to simplify procurement process, and also an update section on single tender waivers to make it clearer when they can be used. So I think that tidies up some of the other areas that have been identified through audit. Turning to where we are at the moment in terms of finance report is also in the pack. The key messages, as ever in the finance pack, really point to the continuation of us needing to hit our agreed outturns by the end of the year. At the moment, we're tracking ICB and system at M8 at around 10 million off plan at the moment. So we've still got some work to do to close that down. And we're focusing, obviously, with organisations just to understand how we can do that together. The ICB, although still at break even, there are some significant pressures which we are covering off through non-recurrent funding at the moment. And obviously that's not great for us as we look forward to 25-26. We're going to do a deep dive on funded care this month, partly because when we last looked at it, it was clear that funded care was an area that we were concerned about, and we're going to go back and have another look because it's tracking not where we would hope, and high cost drugs and devices is the other area that we want to focus on. And we've also got in January a focus on the Section 117s. So we're trying to understand where our costs are at the moment and what we can do to mitigate against those. There's also still the main driver for the deficit is under delivery against the savings targets. We're tracking at 79% on M8, and again we're going to have to push harder to get to a point where we deliver our end of year position. And this is mainly around underperformance against elective recovery plans. So we know where the issues are. The only other thing that Sarah and I know the executives are really focused on across the system is 25-26 is likely to be even tougher. And therefore, the more we can do to get ahead of that this year, the better. But I know that there are challenges, and obviously we're still waiting for information in terms of for the planning round for 25-26. So we're still in the dark, which is not ideal, but not unusual. I think that's probably it. So pressure's still on. We're not tracking where we need to be, and we are taking action to try and understand that and improve that position.
Okay, thanks, Steve. That's very thorough. Before I move into the conversation around financial position, I'll bring Shane in a second. Can I just check with that policy change? If people are happy with that, and if there's anything else, any other questions or anything else anyone wants to raise? If not, I'll presume we're happy to agree that policy change. Okay. So before I bring in Sarah and Deb, Shane, do you want to raise something on the points that Steve's made?
Yeah, so Sarah is no longer in the meeting, Chair, and that's why I just felt I should raise. Sarah has had to head off to something else, unfortunately. A couple of things, Chair, to raise. Our ability to break even this year, we have the Performance and Recovery Board, which is our place where we manage this with providers. But the point that Steve makes is absolutely correct. If providers are unable to deliver on their savings plans or SIP, as we describe it, then our ability to break even, but our ability to spend resource on other things, and that's the important thing. If we're going to make shifts, and we're going to shift left in terms of, hospital community and treatment and prevention, then actually we need to be able to deliver out on the plans we committed to. And that's why we have the Performance and Recovery Board to work with our providers to try to be able to do that, Chair. I also just want to reiterate what Steve had said. We do not yet, as of yet, received planning guidance. We are expecting it, have been expecting it for a while. And it is really clear that the mood music, and I don't think there's anything unusual, people will know that if they read journals or see the news, the mood music is very clear. 25-26 will not be a financially pleasant year. And that's the reality of it. And I think we will be in the position where we need to explore what service change and decommissioning looks like, Chair, if the money is what it is. And I think it's really important to be open and honest with the board that it will be a year of exploring what we need to stop doing as much as what we need to do. And I think it is important just to make the board very well aware of that, because we are not expecting growth money, quite the opposite. We are expecting a tight and maybe a real terms reduction in the money we have to deliver services. So I think it's very important that the board are aware of that, Chair.
Thanks, Shane. I'll open it up to questions.
And if I could just raise one other point in a slightly different way, I think it's important that Debs also is able to come in on this, because we've got some exciting news. So it's not all doom and gloom. Some exciting news in terms of the intelligence centre and what's happening there. So Jeff,
that is where I was going to go next. I was going to go to Deb for that update and then come back to that point around the finances, just give people a chance to digest it. So Deb.
Thanks, Chair. Thanks, Shane. So you'll see from the pack that Steve and the Fed have been presiding over a lot of conversations around the intelligence centre. So we've had lots and lots of conversations about the detail and the procurement. Obviously, the board signed off the OBC back several months ago and delegated the responsibility to Fed to look at the funding. So there's been a lot of work that's been undertaken with Sarah and her team across the executive team, who are each product owners, and right across the system, We've had a number of meetings with local authority colleagues in their senior and exec teams. And we are in a position now where we are due to go out to advert for the Intelligence Centre probably next week. So people may see, it's probably really important for people to know. And if you are approached by any bidders, because there is a very tight market at the moment and there's a lot of interest, if you are approached by bidders, there is an email address with the procurement team, which I'll make sure is circulated out to board members. So you can just divert people, I mean, particularly non-execs, I'm thinking might get approached. If you've got contacts or colleagues, just making sure that you've got the right place to direct that. So it's a big step for this piece of work. And obviously it is all predicated on how well the market responds. We have tried to make sure, given the point about the financial elements, we are actively looking to try and bring that budget in quite significantly without damaging the really important elements that we know we need data for. But the procurement will be really focused on trying to squeeze every possible bit of value out of every possible pound we spend. And then obviously it will come back to the board probably now in April, because we've kind of deferred a little bit for the FBC before we make any commitments about money.
Deb, that's really helpful. I mean, you really are demonstrating how it's progressing, and these things do take time, but there's some really brilliant work in there. And, everything's being affected by the financial position. So you've seen that on the reporting and the papers that have come back in and Shane's update. Happy to take any questions on it. I suspect we're all in the same boat on this around public services and where we are. But the one thing I would say is we are seeing a significant degree of uncertainty about, well, we know it's not good, but also uncertainty about the financial position moving into next year as well. So the sooner we can get that nailed down, the better. But Alison.
Yeah, thanks, Jeff. Thanks, Deb. Good luck with the Intelligence Centre. My questions for Shane were really an observation. I think part of the ICB board role is for the difficult decisions as well as the nice strategic innovation decisions. And I guess the two things that are most important are when we do try something or pilot something or prototype it or introduce something, that we build in a really strong evaluation from the very beginning, and we actually invest in a good evaluation process, which will take us to the point of understanding what adds value and what doesn't. And then the second thing I think we just need to be really super clear on is our decision-making framework, and being really clear about the context and the umbrella of which we may make difficult decisions. So that framework around decision-making. So I think investment in evaluation up at the beginning, which sometimes may not happen, and the decision-making would probably help us in this difficult context.
Okay, thanks, Alison. Sorry, Shane, go on.
No, I think one of the things we did most recently this year with regards to some of the COPD work we did, we built in really strong evaluation at the beginning to understand what the value would be. And obviously then if there is money available, that's how you would use that valuation. You're absolutely right, Alison. We and that's why we're actually looking very strongly at benefits realization and the investment we've made in benefits realization. So I couldn't agree more. In terms of the decision-making framework, yeah, partly here, I totally agree. And I also wonder whether there might be some national mandates around this as well, to be perfectly honest, because it is not a BNSSG problem. It is an NHS problem with regards to how we can deliver service with a reduced amount. So yes, locally, definitely, but I wouldn't be surprised if there was also some national mandates as well.
Yeah, thanks, Shane. Steve?
It's just to look back to an earlier conversation. I'm scanning, and it would be useful if health colleagues did the same, on the Research England websites and NHIR, because there are calls that are out at the moment, especially for some of the areas that Shane's got in his pack, which is around that shift, Shane. There's the potential certainly around diabetes, hypertension, two areas for chronic disease management and remote monitoring. There may be some opportunities in that if we can get a project together and get it funded elsewhere. Frankly, we haven't got the money. So
thanks, Steve. Any other questions around finance estates or digital? Okay, in that case, I'll move us on to primary care then, if I can. Alison?
Thanks very much, Jeff. For completeness, the July minutes are there, but I would have given a verbal update at a previous board about those. So two meetings really about primary care committee, the October meeting, which I'll pull out just a couple of things, and more recently the December meeting where we don't have the minutes. It's been a theme today, but I wanted to reinforce it that we received the annual research report, which talked about there's a really good track record in primary care about research in our area, and I think it's got even stronger. I think with Joe Medhurst being in post, but excellent achievements in numbers of practices undertaking research capability funding, grant applications, and particularly I wanted to pull out the GP DPEN network, which Joe has been instrumental in pulling together, which shows 17 of our GP practices working with the most deprived areas in our population in research and engagement. And Joe may want to come in, but I didn't want that moment to pass. It's a strong foundation, but it's got even better, I think, over the last year. We noted the progress around the National Patient Safety and Incident Reporting Framework, particularly around primary care. Much work to do locally. Local data isn't visible to committee yet. I don't know how visible it is in primary care per se, but there are some national trends which do indicate what the most common themes are of incidents that primary medical services report on. Mostly primary medical services report on other providers about things that may not have gone well or discharge, etc. But on primary care data, there are some national themes. So really, as committee, we are encouraging visibility of more data locally, but also to work perhaps on what the improvements might be in our patch based on the national data. We've talked previously here about the importance of the dental commissioning hub, and that's had some real issues around capacity over the period of time. At the October meeting, we did note Dave was at that point considering downgrading of the corporate risk on the commissioning hub in its ability to help us do what we need to do around dental. And in December, we saw the draft dental strategy, which is on its way to board in March. We supported its journey to board in March. We provided support, we provided challenge, really good work to date there. We supported the need for smart objectives, breaking it down into year 1, 2, and 3. We saw much more detailed BNSSG data on dental areas, and so many areas for improvement. We know we've talked to the board before about visible tooth decay in the under 5s. There's so much more data about the state of people's teeth in BNSSG. So there's a lot of work to be done. Committee will monitor the progress in detail on behalf of the board, but it may be that the board wants to, because the board has shown interest in the dental progress and strategy, board may want a dedicated item, but that took up a good amount of time in December and really good work. Generally, I think we're really lucky to have the people working, supporting primary care under Dave's leadership. I think we've got some really good people providing some good work for us at Primary Care Committee. The other thing to comment on is the progress against the GP Access Recovery Plan, and that is coming to board in March, and that is important for us because we do talk about pressures and urgent care pressures, and this focus of the GP Recovery Plan is about how we help people much more before they even get to the doors of hospitals. So that's an important plan for us. It is coming in March. Lots of good progress, slightly hindered by collective action. And I know Dave's going to update us on both GP collective action and the emerging risk of community pharmacy collective action. But I just wanted to say at the December meeting, as we have before, the strength of the relationships between system partners and the local medical committee at Moncare is really strong, even with the subject of collective action. I think it's respectful, I think it's strong, and I think that will stand us in really good stead for future improvements. Once we can get some stability in terms of the collective action. So Dave, I know it's on the agenda, but maybe that's the point to come in around collective action, if that's okay, Jeff.
Absolutely fine, Alison, and conscious of time. I think what I should note is a bit like the winter plan. We are now in GP collective action, and Jake may want to offer some thoughts from his perspective. So we are we are deep in the managing it and mitigating the actions that are being taken. As Alison has noted, we have maintained excellent working relationships across the system, particularly the LMC in this regard. However, we are in GP collective action, and that's not going to be easy. And there are challenges with that, particularly across the primary and secondary care interface. We have an extensive governance and workstream process to work through each of the actions that are being taken. We have been able to mitigate some of those, and we are still working through mitigations for some of the other actions. We have not been formally made aware of a further phase of collective action, but we have to be prepared that further phase of further actions may come. Sorry, just looking at my notes there briefly. Just to reiterate, in terms of our system governance, the system executive group operates as a gold command. Second time we use that word today. Operates as the gold command, and we are indeed reviewing the actions in progress this afternoon. So just assurance around that governance. In terms of pharmacy collective action, that ballot closed in November for community pharmacy, and again members approved the action. Action has yet to start, and we're awaiting further information about that. But some of the actions that have been proposed could include only opening for minimum hours, withdrawal of free deliveries, and withdrawing services on locally contracted services. And knowing what we know about the amazing progress we've made in community pharmacy access and services over the last few years, it'll obviously be a detriment to our system to see step backwards in that regards. But we again, like the LMC, have an excellent relationship with our pharmacy committee, and we'll continue to work to mitigate any actions as best we can. So it's happening. It's having, it will be, and it is having an impact for providers, but we are working well and have a clear governance process to mitigate.
Thanks, Dave, and thanks, Alison. Dave, can I just check around communication around collective action? Is that being coordinated by the goal group that you're running, or by individual organisations?
So obviously, Jeff, it's within each practice's gift to share information. They would want to. One Care and the GPC and One Care and ourselves offer a communication across practices, and we've been updating the ICB website with comms as well. So all routes as you'd expect.
Okay, it's just that general message to the public around collective action. I mean, we may take a position, we may not, but individual practice, of course, will take their own position. Just wondering whether there's anything from Jacob or Ruth at all on that point. Anything you want to add?
So I mean, I think I would say, we welcome the sort of the proactive support we've had from the system in terms of helping us sort of with a response to collective action. I think it is trying to establish a new baseline of working and trying to make sure that general practice is sustainable for the future, which there's a strong feeling coming through from the GPC and practices that requires more resource. Welcome the pragmatic approach that the system has taken, and the changes that have been put in, particularly for things around eating disorders, that have been really helpful in finding solutions.
Thanks, Jake. Ruth?
Yes, what I would also add is that I know that collective action has been difficult for partners, and so thank you to them, because there was a risk that it would create deterioration of relationships between different parts of the health system, and actually I think it has caused a little bit of a ruffling. But actually, people are accepting that they don't want that to happen, and are speaking openly about the need to continue dialogue and to work together, and to accept that this is a new way of working, and that we need ongoing good and positive relationships between primary and secondary and community care. So I think we have avoided the danger of a breakdown in relationships, which I think is thanks to everybody for their commitment to maintaining that.
Okay, thanks, Ruth. That's really helpful. And just checking if there's any other comments or questions around primary care. So really useful update. Thank you. Audit and Risk Committee. Oh, sorry, Joe.
It was just to respond to the research point that Alison made, and I just had an interesting fact, which I think I'll share with everybody. We talked about this at the Healthcare Professional Executive, and we reflected on, one, the very strong relationships between the universities and the researchers in the health system, which I think really does set us up to be successful. But if you look at the activity across our very research active acute providers and you put it into the community and primary care activity, we have more research activity and funding than Oxford, Cambridge and London. So I just thought it was an interesting fact that people might, to get a sense of where we are here. Yeah. We did reflect, we probably under-egg that, and maybe we should be thinking about how we might use that, leverage that. And as Steve has been mentioned, I think twice on this in this meeting, it is a way of getting resource into the system to do other pieces of change work. So I really do think we can leverage that this year. But I just wanted to share that was an interesting fact.
No, Joe, I think good point. I think it's important that we reinforce that so people realise how much we're actually doing in that space. So thanks. Okay, I'll move us on if I can, because I'm conscious of the time. Audit and Risk Committee, John Cappock's not with us, so I'm not sure there's anything we need to update on there at this stage, unless anybody tells me otherwise. Then the final two committees, the SHIP, well, we've heard a lot about that this morning, so I won't add anything more to that. We've got another meeting now at the beginning of February. Joe's already outlined the agenda for that and the areas that we're going to focus on. So, Joe, unless there's anything that we want to add beyond what we covered in the update on the meeting anyway? No,
nothing, Jeff, no.
Okay, and then finally, the Integrated Care Partnership. A number of us sit on the Integrated Care Partnership, and as we know, the Integrated Care Partnership has a responsibility for setting the strategy for us as an ICB. We have asked that there's a review of that, so going forward, and John O'Neill from South Gloss Council is chairing that group at the moment. It'll pass over to back over to North Somerset in May. We'll have done a full cycle of the 3 local authorities, Health and Wellbeing Board chairs chairing that group. 2 things I would draw to your attention. The first is, if you've had a chance to see it, the Devolution White Paper talks about integrated care partnerships, their role in the future, how the chairs are appointed for ICBs. And so none of that is nailed down yet. Maybe certain time before we start to see that in a different way. But it talks much more around the regional footprint, around what healthcare might look like within a regional footprint. So probably worth a read if you get a chance. The detail's not there yet because it hasn't been passed as legislation, but it is useful. And then the other point I'd add from the Integrated Care Partnership is we've put a lot of time and effort into the locality reviews. We've had a number of conversations on that about whether we've gone far enough on it. But our commitment to being both bottom-up and top-down is absolutely cemented in the way we're operating. And I think people would see that from the way that we are behaving. But Shane, I don't know whether there's anything you'd add on either of those points, whether it be the Devolution White Paper or the locality review. But, I think I've probably covered most of it. But whether there's anything you'd add.
Yeah, I think the Devolution White Paper is a great opportunity for a seminar stroke workshop for the board, because I think it is I know it's white paper, but it is a clear direction. And therefore, I've spoken to Dave Perry, and I see Dave, you got your hand up. I spoke to Dave Perry with the idea that one of our workshops early this year should be around the white paper to help us understand. With regards to the locality paper, it's really important. It connects right back to my paper in my Chief Exec update about the future of neighbourhoods. So we've all been asked to feed back to the chair of the ICP, because the review of localities was an ICP commissioned review. And I believe all partners have. And then we are going to review the feedback at the ICP meeting coming up in January, because I think it is important that we've built strong localities, but what does the neighbourhood health and care system of the future look like? And if we nail down a locality and then suddenly a guidance and thought on a neighbourhood, are we then setting another round of let's review localities? And we don't want to do that. So I think it's really important the ICP gets good feedback and we have the opportunity, the ICP, to discuss the locality review paper.
Shane, I think it's a good point. And Rob, I think we need to add that into the forward planner around seminars. And it's a really good point. Shane hasn't already had that conversation with you. I mean, I would say on integrated care partnerships, there's 42 different iterations across the country. They're not like the ICB where we've had a prescription around pretty much what we look like, not about the way we operate, but the way we look. Integrated care partnerships haven't had that in the same way. And I think the way we're approaching it is quite engaging, and the way we've got local authority elected members chairing those groups, I think is to our credit. We keep saying it. I think there's more that group can do. It hasn't got the responsibility to hold us as an integrated care board to account, but it's certainly not in legislation. But actually, morally, that we should be responding in a way that is reflective of what the integrated care partnership is asking of us. So there's a bit more to do in that space, but I do think we're probably more progressive than some areas around the country. Dave.
Yeah, thanks, Jeff. And just to reinforce Shane's comments, that I think there's a real opportunity here to move forward and drive to that next iteration of what works in local place, and making sure that we get the balance right between being mindful of what's been driven nationally, but also making sure that where we end up is something that works locally for us as well in that space. And again, as you quite rightly said, Jeff, the Integrated Care Partnership is now going through that piece of looking at across all partners, not just the ICB, in respect of how we are achieving against that strategy and pushing that forward. As you've indicated, the English devolution papers are quite a significant shift in direction of travel, certainly for local government, and then into the medium to longer term, the wider systems from a geography perspective. But I think of importance within there is an aim to seek the strengthening between the health system and specifically the strategic authorities, and in our case that's the mayoral combined authority. And given their responsibility in respect of economy, skills, transport, and to a degree housing, it's really important because they are clearly a driver that link into the wider determinants of health and some of that prevention agenda as well. So certainly would support Shane's comments around about having a workshop on that.
Yeah, thanks, Dave. I think it would be very fruitful. And whilst our footprint is more coterminous with WECA than perhaps some other ICBs, there's still a bit more to be done to make sure we are working more collaboratively. So Rob, yeah, we need to make sure we've captured that. Anything else around the Integrated Care Partnership? So I'm conscious of the time, and we had 4 questions. One from Eleanor Roberts, one from Paul Wheeler, one from Bob Krasiak, and one from Syed Abbar, which we will respond to in writing. I always like to raise these as we have conversations at the board. Unfortunately, I don't think we're going to have time to do it today, but we will respond fully in writing to those questions. So my apologies that we haven't had a chance to discuss them, but we will make sure that the replies are done for you and are published. So any other business? Is there anything else anybody wants to raise before we close? So can I just say thank you again? It's a bit more tricky when it's online. We don't necessarily come together and have the same engagement and relationship and in the breaks and things, but we have covered a lot of ground today. And I think in essence, you really can see how we as an ICB are operating more collaboratively, more collegiately. And I get a chance, as does Shane, to see what else is happening elsewhere. And it is not replicated across the country. So a big thank you to everybody for the time and effort that you're putting into the Integrated Care Board. It is appreciated, and I actually do think it's starting to make a big difference for us. So any other business before we finish? Okay, thank you, everybody. See you all soon.
Thanks, Jeff.
Thank you.
Bye. Thanks, Jeff.
Thanks.
Bye.